Thank you. If we could put the slides up, please, or if they're not already up. Lovely, thank you. Okay, well, welcome everyone, and thank you so much for joining. We will go ahead and get started. This is Thematic webinar number 1, and today we'll explore how healthcare financing and reimbursement systems affect access to care for rare tumor risk syndromes, or RTRS, and discuss how we can ensure sustainable funding for prevention and long-term care. This session is part of the Preventable Project funded under Horizon Europe. And my name is Alexis Strader. I'm the Director of Policy and Research at EMA, and I'll be your moderator today. So we're pleased to welcome a very diverse panel of experts in patient advocacy, health economics, healthcare financing, and system level implementation. And they each offer unique perspectives on advancing sustainable care for RTRS across Europe. Before we get started, I'd like to hand it over to Dr. Carla Oliveira, who is the coordinator for the Preventable Project, so she can say a few words to kick us off. Over to you, Dr. Oliveira.
Thank you, Alexis. So my name is Carla Oliveira. I'm here representing the Preventable Consortium as the coordinator. It is a pleasure to be here and see this thematic discussion after the amazing 3 Prevent talks we have had earlier. And today I have the pleasure to open this thematic webinar that has been launched by EMA, here represented by Alexis, in collaboration with SPI, which both of them are partners of our Preventable Project. So these sessions have been an opportunity to bring together experts, researchers, stakeholders, and the objective is actually to share knowledge and challenges, but also to inspire new collaborations and new stakeholders to join the efforts we are making in Preventable to advance the field on the rare tumor risk syndromes field. So if you missed any of the previous Prevent talks, or even if you wish to see this webinar later on, please follow our channels and our website and social media, because everything you wish to find about rare tumor risk syndromes will be there. So I hand you to all our speakers today. I thank all of them. They are representing different levels of the society, and both professionals and also patients. And I'm really, really happy to have you all here. Many thanks. Hand it to you, Alexis.
Thank you very much, Carla, for introducing the work of the Preventable Project. I'll now take the audience through our agenda for today. So we will have a 10-minute presentation by my colleague, Rebecca, and she'll give you an overview of healthcare financing mechanisms and key challenges for RTRS, which will set the stage for our panel discussion. The majority of our time will be devoted to that. We'll be welcoming our 4 guests to the floor to discuss navigating reimbursement pathways and financial challenges in RTRS care. So we're very happy to have them with us. And then I will move to audience Q&A. So please feel free to submit your questions in the Q&A function, and make sure to, and you can do this at any time. You don't need to wait for the panel discussion. I'll give more instructions later, but we welcome your questions. And then I will quickly close at the end since we only have an hour. So now, to frame today's discussion, I'm pleased to welcome my colleague, Rebecca Evelyn Pop, who is a Junior Policy Officer at EMA. Rebecca manages European Commission-funded projects focused on cancer prevention and treatment, and plays a key role in driving policy and stakeholder engagement under Preventable. I'm happy to welcome her to the virtual floor for her to present her research done with the project on healthcare financing mechanisms and key challenges for RTRS. Over to you, Rebecca.
Thank you very much, Alexis. Good afternoon, everyone. My name is Rebecca, and I'm part of the Preventable Project team. I've been leading our work on understanding the challenges patients with rare tumor risk syndromes, also known as RTRS, are facing in accessing care, and on shaping policy recommendations to help improve their support across Europe. In the next few minutes, I will walk you through what we have learned about the financial barriers patients face and what changes we need to improve care and prevention. So let's begin by briefly looking at the European healthcare financing systems and why they matter. Across Europe, health systems vary in how they are financing care. There are three broad models used: tax-funded, social insurance, and mixed systems. However, most countries apply a mix of tax funding and insurance contributions. Each health system defines access to care based on its definition of essential services and the level of available funding. Economic shocks like inflation or crisis limit even more healthcare financing. Therefore, when budgets are tight, long-term specialized services like those needed for RTRS often fall outside standard coverage. While the EU has made progress in setting shared directions for diseases and care, these strategies are not uniformly implemented. This leads to major gaps in how care services are financed and accessed across countries. Regarding rare tumor risk syndromes, there are genetically inherited conditions that significantly increase the risk of developing cancer, often early in life. Though they affect fewer than 5 in 10,000 people, their consequences are serious. These syndromes often go undiagnosed due to their complexity and lack of awareness, which delays care and limits prevention. Economically, the impact is also substantial. Cancer costs the EU around 199 billion euros a year. Prevention in RTRS is not only clinically effective, but also cost-efficient investment in sustainable healthcare. One of the most consistent findings across our analysis is that there are no EU-wide standards for RTRS reimbursement. This leaves individual member states to decide what is covered, and often the result is inconsistency or delay. Specialists across Europe have highlighted persistent resources gaps, including limited funding for multidisciplinary teams, care navigation, and follow-up. Preventive services like genetic counseling, early screening, or even preventive surgery are clinically essential for RTRS, but often not covered. They are seen as costly add-ons, not as a strategic investment. This has a disproportionate effect on asymptomatic patients who urgently need care to prevent future illness, but face some of the highest out-of-pocket costs. These gaps in financing don't just affect systems, they directly impact patients and their families. Patients face delayed diagnosis because access to genetic testing is limited or decentralized. Even after diagnosis, surveillance responsibilities are fragmented, with the burden often falling on the patient to coordinate across multiple providers. And we must also acknowledge the emotional and financial toll. Families navigating RTRS often face psychological stress, logistical complexities, and sometimes significant out-of-pocket payments, all while managing the fear of a cancer diagnosis that may or may not come. Given these challenges in access and reimbursement, it's important to consider the broader role of prevention. Early diagnosis and prevention are not only medically effective, but they also significantly reduce long-term treatment costs by catching disease before it progresses. Yet, despite strong evidence, prevention remains underfunded, particularly in rare conditions like RTRS, where upfront investment is often seen as too high. Broader evidence from the pandemic shows that health systems with strong preventive structures in place were more resilient, managing care disruptions and long-term risk more effectively. For RTRS, what's now needed is clear: reliable long-term funding that embeds prevention and counseling into the health system as a permanent part of standard care. So how do we move forward? The message from professionals and patients is clear. RTRS care must be treated as essential. Dedicated long-term funding must support not just treatment, but also prevention and lifelong monitoring. Out-of-pocket costs must be reduced so that financial means never determine access. And EU coordination must support national reforms, creating a more harmonized and equitable approach to rare care financing. And to close, I want to leave you with a simple message. Prevention is not an expense. It's a cost-saving public health strategy, and funding RTRS today prevents tomorrow cancer and care inequalities. Thank you very much for your attention, and I'm looking forward to the panel discussion.
Thank you so much, Rebecca, for that insightful overview. And I appreciate how your presentation clearly highlighted the complexity of healthcare financing for RTRS care and the very pressing need for more sustainable and equitable funding models across Europe. Okay, so now with our remaining time, let's now turn to our panel discussion. Sorry, and I forgot to put my camera on. There we go. Let's now turn to our panel discussion. I'm honored to introduce our distinguished panelists in no particular order. We have Tamara Husong Malagre. She's the president of the patient organization Evita, Hereditary Cancer Portugal. Next, we have Professor Dr. Sue Mateus, the preventable representative and professor of health economics at Lancaster University in the UK. We have Grace Hampson, Associate Director of the Office of Health Economics, also in the UK. And we have Dr. Christina Kaher, who is the CEO of the Nordic Case Mix Center in Finland. Thank you all so much for joining us. And next, I will dive right into our discussion with some pointed questions for each of our speakers. So I will direct a question to a particular panelist, but of course, other panelists, after they've given their answer, you are also welcome to comment or add to whatever's been said so that we can make this a little bit more interactive, but also so we can hear from everyone. I may have to give you just a time limit so that we are able to go and that I'm able to ask questions to all of our panelists. I ask that you try and not go too long in your answer, but still provide enough detail for us to really understand where you're coming from and your perspective. So with that being said, I also welcome our participants to submit their questions via the Q&A function. You'll find that at the bottom of your screen. And please do indicate if the question is for a particular panelist when you submit the question. Thank you very much. Okay, so first I'll turn to Tamara. Tamara, I'd like to understand what are the most significant financial obstacles that patients with rare tumor risk syndromes typically face throughout their care journey? And when we say care journey, we're talking about from diagnosis to long-term management.
Yeah, so if you are lucky enough to come across with a healthcare provider with sufficient genetic literacy to recognize the pattern of a potential RTRS, because the lack of genetic literacy is the biggest barrier to genetic testing and the consequent identification of genetic variant carriers, or you are already identified as such and live with a RTRS, you are you have the diagnosis is not only the only burden. Every test, every trip to a reference center, every treatment option not reimbursed, it all adds up. Not just euros, but in emotional toll, lost time, and impossible decisions. The patients and families affected by RTRS, we live at intersection of science and survival, hope and hardship. So while medicine may offer answers, the healthcare system often responds with silence, delays, or outright denial. Not because of neglect, but because of barriers built into the very structure of financing care. That's why this webinar is so important to us. It's more than a policy discussion. It's a lifeline for families who feel like their rare condition makes them invisible in the healthcare economy. We need systems that value prevention, that reward early detection, and that recognize the cost of inaction. We need reimbursement pathways that don't leave patients waiting, fighting, or falling through the cracks. We need policies shaped with patients, not for them, just for them. The webinar brings together the right people, I guess, economists, policymakers, clinicians, advocates like myself, to confront what's long been unspoken. The financial barrier don't just affect systems, they affect lives. Sustainable healthcare isn't just a goal for rare and complex disease communities like ours, it's the foundation for survival. So breaking down financial barriers in RTRS care requires coordinated, patient-centered action across several fronts.
Thank you very much, Tamara, for your thoughtful response. And what I'm hearing from you is that it's not just one financial obstacle that's more significant than the other. It's the systemic issues that are built in, as you said, the barriers that are built in, and the families that are invisible in the healthcare economy. So to add to this, I'd like to hear from you, based on your experience and insights, how do variations in reimbursement frameworks across the European region affect patients' access to timely and comprehensive RTRS care across Europe?
That's still a question to me?
Yes,
yeah,
it is.
We notice huge inequity in access. It really depends on your address, where you live, how good will be the care you receive. That's a very outstanding fact, unfortunately. So we think that the equitable access has to be a priority. Anyways, we are talking about syndromes that have a very big opportunity for prevention, or at least early diagnosis. So for sure, we can prevent a lot of waste for the systems. We think that the shift of mindset in policymakers to invest more in prevention and early detection, and not always try to we have more sick care systems than healthcare systems. We really need to emphasize prevention and early detection. This investment will turn out in huge savings for the systems. And I really hope, and I know first numbers are out from Preventable Project, and they show what we all already know. It's the common sense. If you prevent disease, you will save a lot of money, and most of all, we can save many lives.
Thank you. And speaking of our early results, I would like to now turn to Sue, because Sue has been working on these early results in her cost effectiveness analyses, her and the team at Lancaster University. So Sue, could you talk to us about how feasible would it be for decision makers to systematically integrate cost effectiveness analysis into national rare disease financing strategies?
Thank you very much. Thank you very much, Rebecca, for the very nice presentation. Thank you very much for the question, Alexis. I think that the systematic approach that will be taken regarding prevention of rare syndrome tumors for in the different healthcare systems will be similar to the approach that is taken for the financing of other diseases. I know that this is not really the answer that families and patients and physicians working in the field would be really keen to hear. But policymakers, they have to pay attention to all the patients with all the diseases, so that they will be taken this information into consideration as they take the same kind of evidence to support other decisions and other preventive measures that are being brought into the healthcare systems more and more, because what is clearly understood by everyone, and there is a general agreement, is that it's more important to prevent a disease to happen than to treat it. And it's more important because usually it's you are going to use fewer resources when you prevent than when you treat. But at the same time, it's quite difficult then to understand what are you preventing if then the disease doesn't happen. So how can we make payment for something that we are avoiding and that we can't see taking place? So, but hopefully there is a quite widespread message at the moment again around healthy lifestyles that prevent a lot of the things, not this genetic hereditary syndrome. So it's also important to make the difference that we understand that diseases are not all the same and the mechanisms are not all the same. So different measures might be necessary. But what we also know that is shared by all healthcare systems, that there is a huge constraint on resources, because fortunately we are able to treat more and more diseases. We are able to expand life expectancy to more and more people. So obviously that this makes resources scarce in all the countries. So of course that we have to act smartly, and to try to bring evidence as much as possible into the decision-making process.
Absolutely. Thank you, Sue, for that and providing your expertise. I just have a follow-up question. Because you touched on the same as Tamara and the importance of prevention. We have learned this first and foremost in the Preventable Project. But what I want to know is, how do you, or what might be the consequences if healthcare systems focus on short-term costs and overlook the long-term savings? And you kind of hinted at this, but could you expand a little bit on what are the consequences, and especially in terms of people at risk of rare tumor syndrome?
Sure. I think that we are working on two different dimensions, because the relevance of prevention, it's not only for the healthcare system itself, but it's for society as a whole. And that is where we have a long-term perspective, because the management of healthcare systems, it's more short-term, so it's more determined by sometimes unanticipated events like COVID and other sorts of diseases and things that weren't treatable and became treatable, new treatments that become available and that also take a large portion of resources. So a lot of things have to be managed in the short term, and so I don't think that is surprising or shocking that the management of healthcare systems and the funding is done more on a short term. But what we all need to have into consideration is, as society, all countries will benefit from a long-term approach. And in that situation, we are concerned not only with treating people that become sick, but we are concerned on having a healthy population that can contribute for society and can live longer, and bring impacts in many domains, joy to the families, have a fulfilling life, being able to work, pay taxes, okay, and all sorts of things. So I think that these are two different approaches. And the perspective that we need to have for the management of the healthcare system is different from the one that we as citizens, wish our countries to have regarding society as a whole.
Well, thank you for your perspective, Sue. And I recognize it's quite a complex issue, and we do come with different perspectives. In terms of perspective, I'd like to hear yours, Grace. Now, talking about the economic argument for prioritizing rare diseases like RTRS, in your view, what is the strongest argument in national healthcare financing, and why does this matter most?
Thank you. So I think there's various ways we can look at this. So let's start with the prevention angle, which has already been mentioned by all of our speakers. So across the board, we know that prevention is more cost effective than treatment. We know it's a smart use of public funds, smart use of private funds as well. Prevention is typically considered to be around 3 to 4 times more cost effective than treatment and offers higher returns on investment. Obviously, it's very good for individuals whose health capital is of high importance to them. It's also great for the health system, as we've just been hearing. We know that budgets are tight and unnecessary spending on preventable conditions is adding additional pressure. Health and social care systems are already struggling to deliver the care that's needed, and we know that these health needs and healthcare demands are only set to increase. We have waiting lists at a historic high, staff shortages are rife, the staff that we do have in place are recording high stress, low morale, the estate is crumbling, systems are outdated. So averting demand that could further disrupt the functioning of the healthcare system is really crucial. So if we can use prevention to protect against the worsening of this situation, then that's obviously something that we should look at. Again, it's already been touched on, but outside of the health system, we know that prevention is also good for governments and society. So many of the problems we're facing, we're seeing stagnant labour productivity, stagnant economic growth. We have a sick workforce with huge numbers of people not working due to ill health, perhaps also their family members or carers also not working so they can look after them. So the cost of lost productivity, the economy is due to preventable ill health is really quite substantial. And there's also, through prevention, we could also potentially reduce things like tax receipts, increase tax receipts, reduce welfare payments. The list goes on. Put very simply, the cost of not preventing is much higher than the cost of prevention. So that's kind of the economic prevention angle, and it's a technical answer because it's to do with allocative efficiency and how you efficiently allocate resources, in that we know that prevention is a better use of money than treatment and there is a high return on investment. So there's a technical allocative efficiency argument. But thinking specifically about rare tumour risk syndromes, all of that prevention argument apply, and we've already heard that prevention is showing to be cost effective in this space. But there may also be an additional argument here based on public preferences where we're talking about preventing and treating severe cancers. So public preferences are relevant because the general population ultimately pay for healthcare either through taxes or through insurance premiums. And we have preferences over what type of conditions should be given high priority. And we have strong evidence that suggests that the public is willing to prioritise health gains to patients in more severe health states. To the extent that there is an overlap between rarity and severity, there is quite a high overlap. This may justify greater priority for small patient populations, but certainly severe patient populations. So there's a combination here of prevention being a smart move economically, but also that extra rationale for investment here as society seems to care more, or does care more, is evidence to care more about treating those severe conditions. I should say, we know that people are not entirely driven by evidence. So the evidence does support investment and funding here, but as we've already heard, there are still barriers, and ultimately spending money on patients that appear to be healthy is very difficult when you have patients in front of you that are very sick. And that sort of emotive and political challenge is what the economic evidence keeps butting up against.
Very well put, Grace. Thank you for that and for bringing in not only the technical and economic perspective, but also the political and emotional, because all of this needs to be considered. And what really stuck out to me was, what you said about in terms of prevention, averting demand from an already overburdened healthcare system, because we are very aware that it's already quite overburdened. Which brings me to my next question for you is, if we're looking, so understanding that, we can look at traditional reimbursement structures in public healthcare funding, but we can also look at additional mechanisms to help fill in the gaps and cover some of these costs. Are there any additional mechanisms from your perspective that you think could enhance the financial sustainability of rare diseases such as RTRS?
So, I mean, there's a lot going on there. So, to start with, you mentioned both reimbursement structures and funding. I'd like to draw a distinction between these two, where reimbursement structures, at least to me, is to do with how reimbursement is made, perhaps including how much, and then funding, which to me is more about where the money comes from. And we can probably argue over exactly what fits in where and how the wording should be. But the point of this distinction is that there are various ways in which we can look at where funding comes from, or how money is paid, or even how financial mechanisms can incentivize research and development and innovation in this space. And what we do and how we use each of those depends on what we're trying to achieve. I think really the crux of your question is about funding. So let's talk about funding for now. So we can think about funding from within healthcare systems, and we can think about funding from outside of healthcare systems. So let's start with within. So there are various different tools that we could use to mandate funding or spending on prevention, either within the space or more broader prevention from within the healthcare budget. So for an example, in the UK, we have a mental health investment standard, which essentially has a minimum amount that you can spend on mental health of your healthcare budget, and that increases over time. So there could be something to mirror that for prevention or specific types of prevention, maybe early detection screening. Thinking about financing from outside of healthcare budgets, again, there are various tools that have been discussed in the literature. So we have social impact bonds, for example. These have been piloted within prevention. They're essentially outcome-based contracts between a government and an investor, typically a philanthropic, it's hard to say, investor. And essentially the return on investment links directly to the project's success in delivering preventative care. So if the outcomes are met, then whoever's funding the program, so the government or the health system, repays the investors their initial investment plus a return. These have been fairly effective, but they tend to be small scale. People may also talk about dedicated prevention fund, so that this could be conceptually similar to innovation funds that we see in various countries. So we have the Cancer Drugs Fund in the UK, there's the Innovative Medicines Funds in Italy, and these are typically for highly innovative medicinal products. But why can't we also have one of these for prevention, which we know has a better return on investment than these other interventions? Still, we'd need to talk about where that money was coming from. Could it come from national government if we were to recognise that health is an economic investment? Could it come from philanthropic donors? Maybe that would be more likely in low resource settings. Various other more technical or clever financing mechanisms have also been suggested, so using blended finance, business relief. But these all require some way to provide returns back to the investor. So, there's no such thing as a free lunch. We're doing some work in this space at OHE at the moment to look at funding mechanisms for prevention as part of our programme of research called the Change Initiative. So that's ongoing. But I guess just to conclude, I want to just reiterate what I said before, which is around, alongside those economic solutions, we need political solutions. So we need prevention, early detection, screening to be elevated above these short-term political gains, short-term budget cycles, and seen as an investment. Benefits span individuals, health systems, societies, governments, and shouldn't be denied by any government or political party due to short-sightedness.
A very important point. Thank you, Grace. Thanks for your comprehensive response and for differentiating the different types of funding mechanisms and tools that we're looking at, and how that differs from the reimbursement model, which is obviously different. So I appreciate that. I'd like to finally turn to Christina, and going back to talking about reimbursement models. Can you provide your perspective on a key consideration when designing reimbursement models for rare or complex conditions?
Yeah, thank you very much. And first of all, thank you for having me. And it's an honor to be a part of this distinguished panel here. I like that Grace actually differentiate the funding and reimbursement, because I agree that these are a bit different things. Now, when it comes to the key considerations for designing reimbursement for rare diseases or rare conditions, I think it's important to find a balance between the patient access and outcome, and on the other hand, high cost and often limited evidence base of specialized treatment. So there are like critical points I would like to highlight or address. Is high cost. We know that the treatment of rare conditions often involve high specialized innovative therapies, which come with extremely high price tag. Then the limited evidence, the conditions are rare, so there are clinical trials are often involving small patient cohorts, which are leading to less robust long-term efficacy data compared to the treatments for more common diseases, and also the patient access, which has been mentioned already, and also outcome. So this reimbursement model must ensure that the patient have access, because often they have life-threatening conditions, so they have to have access to the life-saving treatments and interventions, and also achieve the best possible health outcomes. So designing this reimbursement model, these aspects have to be taken into account so that it is financially sustainable while meeting the patient needs. And therefore, I think the key consideration really is to find approaches that link this payment to the patient outcomes, and also managing financial risk, because it's also a big burden and financial risk for the payer. Is it governmental institutions or insurance companies or whatever? So I think these are the key consideration when designing the reimbursement model. I know it's easier to say than implement, and I think most of the countries have tried and probably have also succeeded. But I still there is it's not let's say conventional way of reimbursing diseases which have very high evidence in the societies.
Thanks, Christina. Indeed, it's important to highlight the fact that the high cost of treatment, and that there are small patient cohorts. And I think this was also, something that Rebecca touched on in her presentation earlier. And meanwhile, the cost to patients are piling up and causing additional stress, which of course we can only imagine they are already stressed from having this diagnosis. So I appreciate your input on that. I'd like now to hear from your perspective in terms of funding frameworks. We talked a lot about prevention, so this is again focus on prevention, because we by now have concluded the importance of this, and I want to reiterate it. What's the biggest challenge to, in your point of view, integrating preventive care into standard funding frameworks?
I think many things have been mentioned already, but I think the biggest challenge comes down to the short-term focus versus the long-term and diffuse benefits of prevention. And we can talk about the time lag, because the positive outcomes of preventive care often comes with delays. It may take years or perhaps even decades, and also the attribution difficulty. And what I mean by that is that it's hard to precisely attribute saved cost or improved health outcomes to specific preventive interventions, especially given that many other factors actually influence health. And this makes it difficult to justify upfront investments to preventive care and in a standard, say, funding frameworks. And we know that the preventive services may have significant upfront cost, but then comes this long-term benefit, and this is often forgotten in this short-term budget cycles, which is usually the way how the insurers are operating. And the other aspect here, I think, is this siloed funding. We have funds for acute care, we have funds for let's say, primary care, and this public health is often having this smaller and separate part, and this preventive actions or interventions are often part of the public like health initiatives, and this makes it very difficult to seamlessly integrate these two like silos, so to speak. So yeah, and I think it's also about the incentives that different financing mechanisms give to providers, because hospitals are mainly incentivized to treat the patients who have illness or severe kind of diseases already. So they are not really incentivized to deal with the prevention. So yeah, this is something that I would address when it comes to the prevention, integrating prevention into this conventional, let's say, funding model.
Thank you, Christina. And I think very well put indeed. The issue is the short funding cycle, something that Grace and others also touched upon, that with political changes, often these longer term investments are overlooked or set aside for shorter term wins. And the siloed funding also makes an argument for more collaboration at the regional level. Especially in terms of RTRS, where there are so few patients at the national level, but if we can pool resources at a regional level, it may be more beneficial overall. So I appreciate your perspectives on that. So I would like to move to our audience Q&A. I did mention to our audience members that we are open for questions, and we welcome you to put your questions in the Q&A function. While we wait for any questions from our participants, I will continue to ask questions that I have prepared for you all, and these are for anyone to answer. So if you feel compelled, or more than one of you feels compelled to answer, you are very much welcome. Or comment on what other panelists have said, that is also definitely welcome. So first, I know this could be perhaps idealistic, but and maybe difficult to do, but if you could recommend one change, like just one, to make reimbursement systems more responsive to rare or hereditary conditions, what would it be?
You can kick us off while the others are thinking, if you like. So for me, this is not purely economic, but it's linked to what the economic evidence shows. And again, it's something we've all said, is that health systems, rather than the reimbursement systems themselves, need to see health, or society needs to see health as an investment in society and in the future of the economy and then the future of health systems. Health systems around the world state that prevention is a priority, and I would like to see that reflected in funding. So in the UK, for example, we've had in real terms, a 25% cut in prevention funding over the last 10 years. And this is at the same time that the government is saying over and over again that prevention is a priority. So whether that funding comes from within health budgets or without health budgets will obviously be context specific, and it's not, obviously it's easier said than done. But I would really like the funding to match what is stated as a priority.
Exactly, Grace. Put your money where your mouth is, which is what you said earlier. And I know it's a colloquial phrase, but I think we all get it, indeed. So thank you for that. Any other panelists you want to weigh in on this one change that you would make?
Yeah, I can also take this. I think that many times we think that prevention only takes place within the healthcare system, and it can only come out of the healthcare budget. But there are many other domains, namely industrial policy, where we can have changes that have an impact on the health of the population. So we also need to be more imaginative regarding the answers that we might have. Because, for instance, now in many countries, there have been policies where sugary beverages or sweetened beverages have taxes, okay? And that has decreased the consumption of beverages with added sugar. And that has a positive impact on the health of the population, because then you have fewer people getting obese, and that also leads to other behavioral changes regarding eating that is part of a healthy lifestyle. And we also can have these kind of interventions in other domains, not only by imposing taxes, but also kind of getting people into adopting healthier behaviors regarding, for instance, physical activity, or trying to have better work-life balance, people with less stress, and more time to relax and to sleep better. So there are many other things that can be done, not only, and prevention, it doesn't take place only within the healthcare system. So I think that there is also a need to convey this information in a different way, so more people can understand that it's not only it's not putting the responsibility on the individuals alone, but there are other things that we can do for ourselves that also can improve our health, and we also can demand from our governments other measures besides investing in the healthcare sector. Having said this, I also share Grace's concerns about the cuts in many healthcare budgets in different ways. It's not only the direct cuts in healthcare budgets, but also now in many countries, cuts in research that will have an impact in what we can address, and give answers to in terms of healthcare problems in the short term, because we are not only talking about impact in 10 or 15 years, we are already talking about impact from the cuts of research and also, of course, cuts in the healthcare budgets within the next 2 or 3 years. That is, hopefully all of us will still be alive by then. So we are all concerned by this.
So I can also answer from the patient perspective.
Sure.
I think it's very important to involve patients in any financial decision-making process, because patients understand the invisible costs, like missing work, traveling, psychological burden, and so on and so forth. I think that's a very easy and quick step to bring in the true social value or in the decision-making process.
Thank you very much. Please go ahead, Christina.
Yeah, just, and this is imaginary kind of or wishful thinking, but if I were a minister of health of imaginary country, and there is one thing, of course, it's not so easy and much more complex, but I think it should be the reimbursement system should be more flexible and more dynamic to meet these very specific needs of patients with rare diseases. And probably the combination of public funding and private investments, and also these philanthropic donations and fundraising initiatives, probably should be, and they are part of the system. And it's probably unlikely that these donations and fundraising initiatives will disappear, because they, at least, well, I don't know, of course, how it is in every country, but countries I work with, and I know that this is actually an essential part of funds which comes through this like alternative, let's say, outside the public or insurance-based system. So yeah, as said, it should be more dynamic and flexible just to meet the needs, perhaps to summarize what I would do or what is one thing. But I know again that this is not easy to change. It's quite a complex and a rigid system to change.
Thank you very much for humoring me with this question. And, we heard put your money where your mouth is. We heard from Sue to look outside of the health investments in the healthcare system to perhaps investments from the industrial policy side. She gave the example of taxes on sugar beverages. And Tamara highlighted the importance of involving patients so that they can share their perspective on the invisible costs that they face that aren't often considered. And Christina wished for more flexible reimbursement models that better meet the needs of patients. So I also see that Grace, you sent a message in the chat, but would you mind opening this up to the group?
Sure, yeah. So it was a note based on what Christina said as part of her sort of opening remarks, which is around the way we incentivize healthcare practitioners. And at the moment, hospitals are paid to treat patients. Is there space? Can we do something a bit wackier and, for example, pay GPs to keep patients healthy?
Well, again, I don't know what are the competence in other countries of primary healthcare providers, for example, because they have very kind of wide qualification, but not going into the tiny details. And I think these rare diseases are actually the area where you need very expertise and knowledge, and primary healthcare providers might not meet these needs, and they are not meant for that to treat these patients with rare diseases. But yeah, I think it's as I said, it's easy to say, and not that easy to find a solution. I think some of you mentioned that the patient for payment for or paying for outcomes and paying for value is probably something what we can consider again, how to incentivize and how to build the system which is taking this into account and assessing this value, which we can then put the price tag and say that this costs that much, and then through this incentivize the providers. But I don't have answer to this question, but I think it's important to discuss and keep these discussions up and also raise the awareness of these issues related to the treatment of patients with rare diseases.
I think we are already in an optimistic step ahead because we are trying to break down financial barriers. We have a bigger problem, which is the identification of genetic variant carriers of RTRS in the first place. So the lack of genetic literacy in healthcare professionals outside oncology or medical genetics is huge. And we have only a few carriers identified nowadays. We have one gene altered, and we have a group of organs at risk. So it's quite likely that they will develop some kind of cancer. And we have the early onset of disease. So we are talking about young adults in the peak of productivity and fertility. Those are all huge impacts. And I wish that we start with a better identification of genetic variant carriers in the first place, which includes, of course, education and maybe digital tools to help the identification of those carriers. And then the second step is the already identified, how do we optimize the care pathway of this RTRS patient? But it's difficult. Philanthropy is also a cultural problem, I wanted to say. I can tell that in Portugal, philanthropism is not a thing. If we look at the United States, it's completely different, for example. So this is also wishful thinking, which I totally agree. I don't know how to get there, but we have a lot of work still ahead, and I'm happy to have all these specialists on board to do brainstorming about better care for RTRS patients.
Thank you for your thoughts, Tamara, and thank you to all of our panelists for sharing your thoughts and for the discussion. And definitely a positive note, Tamara, to end on there with we so grateful to have these experts here who are working on better patient outcomes for those suffering from rare tumor risk syndromes and other rare diseases, because in different ways, of course, but you're contributing significantly, and we thank you for that. I'm afraid that's all the time we have for today's webinar. But again, thank you all for your participation. First, thank you to our speakers for very much a very rich discussion, and thank you to all of the participants who joined us online today. As we said at the beginning, a recording of this webinar will be made available shortly on the Preventable YouTube channel. So please feel free to share with your professional networks and those who couldn't join us today. You're also welcome to follow us for project updates, either on the Preventable website, which is preventable.eu, or by following us on social media. And with that, on behalf of the Preventable Consortium and Emma, we hope you'll stay connected as we continue to shape a more equitable and integrated future for RTRS care in Europe. Thank you all very much.
Thank you. Bye-bye.